Welcome back to the deep dive. Today, we're digging into something that touches so many lives, the latest medical thinking on problematic alcohol use. You might think the conversation hasn't changed much, but, well, the healthcare definitions, they've really moved on.
They absolutely have. And our mission today really is to give you a clear view of what's changed. We're going straight to the guidelines, the source material, to understand the big shift in terminology,
Uh-huh.
also the surprising number of hidden cases out there, and importantly, what interventions actually work.
Right. And first up is just the language itself. We used to hear terms like, alcohol misuse or alcohol dependence.
Yeah, those are basically obsolete now in the official guidelines.
So it replaced them.
It's now a single term, alcohol use disorder, or AUD. This lines everything up with standards like the DSM-5. It's much more about the actual impact of the drinking, less subjective.
Okay, AUD. Got it.
And that's a big step for identifying it earlier.
Okay, let's unpack this definition, though. Because often, I think, we focus purely on how much someone drinks, right? Like the number of glasses.
That's a really common thought, but no, the diagnosis isn't just about volume. I mean, volume matters as a risk factor, sure. But AUD is defined by a pattern of drinking that leads to problems. Physical issues, psychological, social problems. Or maybe it just stops you dealing with other things you need to deal with.
It's about the consequences, the impairment.
Exactly. Functional impairment is key.
Okay. So the DSM-5 criteria, there are 11 of them? That sounds like a lot for someone to remember, or even a doctor to check off easily.
It does, but you can group them. Makes it easier to grasp. Think of it in like three main buckets.
Okay.
First, there's loss of control. So drinking more than you meant to, wanting to cut it down but not being able to, spending loads of time drinking or recovering, that sort of thing.
Right, loss of control. Makes sense.
Second bucket, social and functional impairment. This is where it affects your life roles, work, home. Maybe giving up activities you used to care about, or drinking in risky situations like before driving.
Okay, that's clear. And the third?
Third is physical adaptation. This means tolerance needing more alcohol for the same effect, or experiencing actual withdrawal symptoms if you stop.
And you only need how many of these?
Just two. Two or more of those 11 criteria within a one-year period, and that meets the definition for an alcohol use disorder.
2 doesn't sound like a very high bar.
Well, it reflects that even a couple of these recurring issues indicate a significant problem is developing or already there.
Okay. What about binge drinking? That term gets thrown around a lot. How's that defined clinically?
Good question. Binge drinking is specifically about drinking a lot in a short period, often followed by periods of not drinking at all. The threshold is usually defined as 5 standard units of alcohol for men or 4 units for women on a single occasion.
And let's just remind people, 1 unit is roughly 10 grams of pure alcohol. So 4 or 5 units. That's like 4 or 5 standard glasses of wine or regular beers, maybe in an evening.
Yeah, exactly. Consumed over, say, a couple hours. That context helps understand the immediate risk.
Now, here's something that really jumped out at me from the sources, the hidden scale of this. If the definition is clearer now, why are so many cases apparently missed?
It's actually quite startling. The data suggests a typical GP practice, maybe around 2,000 patients or so, is likely to have somewhere between 100 and 150 patients with problematic alcohol use. But only a fraction of those are officially known to the doctor.
100 to 150 out of 2,000.
That's the estimate. And the general population rate is about 4%, much higher in men, maybe 3 to 1. So yeah, it's far more widespread and frankly more invisible than most people realize.
If treatment in primary care can be effective, which we'll get to, why this huge gap? Is it just patients hiding it? Denial?
Denial plays a part, definitely. But a huge issue is that people often come in with indirect sign. They don't say, "Doc, I think I drink too much."
Right.
They come in with vague physical things. The doctor treats the symptom, maybe fatigue or stomach issues, but doesn't always connect the dots back to alcohol.
Okay, so what are those specific indirect signals, the things that should maybe set off alarm bells for a doctor or even, family or friends?
There are several key patterns. Frequent doctor visits with complaints that seem vague or they change a lot or just can't be easily explained medically. Things like constant tiredness, hand tremors, heart palpitations, maybe sweating a lot. Gastrointestinal problems are a big one. Chronic heartburn or reflux, gastritis, pancreatitis, or more advanced signs like liver issues.
Anything else?
Yeah. Also look for psychosocial problems combined with bad insomnia. Often leads to people repeatedly asking for sleeping pills or tranquilizers.
Ah, right. Masking the underlying issue.
Exactly. And then there are things like unexplained collapses, blackouts, or maybe frequent accidents, falls, fractures,
Yeah.
and sometimes visible physical signs like tiny red spider veins on the skin or a kind of puffy reddish face.
Wow. Okay, some of that sounds like, well, just being tired and stressed, doesn't it?
Okay.
Which makes it easy to see how it gets missed.
It does. That's why it's often the pattern, the combination of these things. That's the real clue, not just one isolated symptom.
And talking about severe consequences, let's touch on the Wernicke-Korsakoff connection. This seems like a really critical piece of the neurological risk.
It's incredibly serious. It stems from a severe deficiency in thiamine, which is vitamin B1. This happens a lot with chronic heavy drinking, usually alongside poor nutrition.
Okay.
The immediate danger is something called Wernicke encephalopathy. That presents acutely with confusion, trouble walking ataxia, and very specific problems with eye movements.
And that's reversible.
It can be, if caught and treated aggressively with high-dose thiamine immediately. But if it's missed or delayed, it can cause permanent brain damage and progress to Korsakoff syndrome.
Which is the severe memory loss part.
Profound memory loss,
Yeah.
yeah. And problems with planning, organizing thoughts, executive function. It's devastating and largely irreversible at that stage.
So it's less the alcohol directly frying the brain cells and more the vitamin deficiency caused by the chronic alcohol use pattern.
That's a good way to put it.
Mm.
The alcohol use leads to the deficiency, which then causes the neurological damage. And that's precisely why giving thiamine supplements during alcohol withdrawal is absolutely standard practice, sometimes even before withdrawal starts if someone's high risk. It's preventative.
Beyond the devastating personal health costs, what about the wider impact?
Oh, the societal cost is enormous. Think about domestic violence, child abuse, problems at work, school dropouts, crime related to alcohol. Just looking at the Netherlands back in 2011, the estimated economic burden was already around 3.7 billion per year.
3.7 billion.
Billion, yes. And you can bet that number hasn't gone down.
Let's pivot now to young people, say ages 12 to 20. The sources really hammer home that adolescence is this unique, very sensitive time for brain development.
It really is. The brain is undergoing massive changes. Maturation, connections being pruned and reformed. It's like major construction work is happening.
And alcohol interferes with that.
It appears to have a direct negative effect, yeah. Especially repeated binge drinking. There's growing evidence, including from MRI scans, suggesting it can lead to actual structural changes.
Structural changes? Like what?
Things like smaller volumes of white matter, which is crucial for communication between brain regions, and also a smaller hippocampus.
The hippocampus, that's memory, right?
Exactly, the brain's key memory center.
So what does that actually mean for a teenager? How does that show up?
It translates into real-world cognitive problems.
Yeah.
Difficulties with memory, obviously, but also attention, planning skills, how quickly they process information. You often see it linked to declining school performance, poorer judgment.
And do we know if that damage is permanent?
That's the worrying part. We don't fully understand yet how reversible this damage might be long-term. Some functions might recover with abstinence, but some changes could persist.
And then there are the immediate dangers. We hear stories about coma drinking.
Yeah, the rise in hospital admissions for acute alcohol intoxication among young people has been really alarming. Part of the issue is that teenagers often don't feel the intoxicating effects, like dizziness or sedation, as strongly or as quickly as adults do.
So they just keep drinking.
They keep drinking, often way past safe limits, until suddenly the effects hit them all at once, leading to collapse, unconsciousness, acute intoxication. The stats showed admissions for kids 16 and under quadrupled in just a decade, between 2001 and 2011. It's a serious trend.
If you're a parent or work with young people, what are the behavioral red flags you should be watching out for?
Keep an eye out for sudden shifts in behavior, losing interest in hobbies they used to love, a noticeable and sustained drop in school grades, skipping school. Also, look for other risky behaviors popping up alongside, drinking like cannabis or other drug use, or increased sexual risk-taking.
And context matters, too.
Absolutely. Any contact with the police or significant family problems, and especially if there's already problematic alcohol use by parents in the home, that's a major risk factor.
So what's the single most effective piece of advice for parents trying to prevent this?
The evidence points strongly towards one main goal: delaying the age they start drinking for as long as possible. Every year, delayed makes a difference.
How do parents achieve that?
Clear rules, consistently communicated, whether that's a strict no alcohol rule or very clearly defined limits if they are older teens. And crucially, parents need to understand their own role model function. Having those open conversations and clear boundaries really does reduce the risk of their kids developing alcohol problems down the line.
Okay, let's talk about treatment, because it's not all bleak. For many people with problematic use or maybe a mild to moderate AUD, where does help usually start? Does everyone need specialist rehab?
No, absolutely not. That's a key message. The vast majority of adults, and young people too, with problematic use can actually be treated effectively right there in primary care by their GP.
Really?
Yes. And starting treatment early is much, much more effective than waiting until things get really severe.
So what tools does a GP have besides just telling someone to cut back? What non-medication approaches work?
Two main things stand out. Motivational interviewing, often called MI and brief interventions.
Okay, motivational interviewing, what's that involve?
It's a counseling style, really. It's non-confrontational. It kind of accepts where the patient is at, even if they're unsure about changing. The focus is on exploring their reasons for potentially changing versus staying the same. It helps them explore the pros and cons of their drinking, highlights the gap between their goals and their behavior, what we call cognitive dissonance, to build their own internal motivation to change. It follows the stages of change model.
Helping them find their own why.
Exactly. Not telling them what to do, but helping them figure it out.
And brief interventions. That sounds, well, brief, like 1 to 4 sessions. How can that possibly work for something like long-term drinking habits?
It sounds surprising, I know, but they are remarkably effective, especially for people whose AUD isn't yet severe. Often, the motivation is there, just maybe buried. These short sessions are very cost-effective. They've been shown to significantly reduce overall alcohol consumption and how often people binge drink, especially in men. Sometimes just raising awareness and setting a clear goal is enough to start a change.
What about people who are hesitant to even go to the GP about this? Too embarrassed, maybe?
Yeah, that's where e-mental health comes in. Online self-help programs can be a great option. They're low threshold, anonymous. The key is the person needs to be motivated enough to actually use the program. But for those who are, these digital tools are shown to be much more effective than just, say, reading a leaflet.
Okay, let's talk medication then. For someone who is stopping and is at risk of withdrawal, what's the standard approach?
If someone has moderate to severe withdrawal symptoms, which can be dangerous, risk of seizures, delirium tremens, the first-line medication is usually a benzodiazepine, like lorazepam.
To manage the acute symptoms safely.
Precisely, to stabilize them during that initial detox phase.
And what about medications to help prevent relapse long-term? Things like naltrexone or disulfiram. Does the GP usually prescribe those?
Generally, no. Those medications, acamprosate is another one, are typically initiated and managed by specialist addiction services, not routinely by the GP.
Why is that?
Couple of reasons. There are safety concerns, especially with disulfiram. You can get very sick if you drink while taking it. And honestly, the evidence for their effectiveness when prescribed solely in a primary care setting isn't as strong as when they're part of a broader specialist treatment plan.
Right, so it needs more support around it.
Often, yes.
So when should a GP refer someone on to specialist care? Or maybe even an inpatient detox? What's the threshold?
A referral is definitely needed if the alcohol use disorder is severe, say meeting 6 or more of those DSM-5 criteria we talked about.
Okay, severity is one factor.
Other key reasons include serious mental health problems alongside the drinking, like psychosis or high suicide risk. Also, if someone is using multiple substances, not just alcohol.
Right.
And factors like being older with poor physical health or simply not having enough support or supervision at home to manage withdrawal safely. Those cases really need a more intensive, specialized approach.
Okay, before we finish, we really need to cover the current advice on drinking levels because the guidelines changed significantly around 2015, didn't they? What's the recommendation now for minimizing health risks?
It's very clear and quite a shift from older advice. The current guideline is drink no alcohol, or if you do, drink at most 1 glass per day.
1 glass maximum.
Yes, and this is crucial, not every day.
Wow. That's a world away from older guidelines that might have allowed, 2 drinks for men. You mentioned cancer risk earlier as a driver for this change.
That was a huge factor, yes. The rationale is all about minimizing risk for major chronic diseases. The evidence became undeniable that higher alcohol use significantly bumps up the risk for early death, stroke, several cancers, colon, lung. But the really striking data was on breast cancer in women.
Even with just moderate drinking?
Yes. Even what was previously considered moderate, regular drinking showed a clear increased risk for breast cancer. That finding really changed the whole risk-benefit calculation.
So the idea that maybe a little bit of alcohol was good for the heart.
That idea has been largely outweighed. Any potential small benefit for cardiovascular health, which was mostly seen in older adults anyway, is vastly overshadowed by the increased risk of multiple cancers and other serious health problems for the general population.
So basically the safest amount is 0.
Medically speaking, yes. If optimal health and lowest cancer risk is the goal, then 0 is the answer.
So the 1 glass max, not daily, is sort of a pragmatic upper limit acknowledging societal norms rather than an endorsement.
You can certainly interpret it that way. It represents the maximum level before the health risks really start to climb undeniably for most people.
And one last practical point, driving. We all know drinking impairs judgment and reaction time, but how long does it actually take for your body to process just one standard unit of alcohol?
On average, it takes about 1.5 hours for the body to metabolize and eliminate the alcohol from one standard unit.
An hour and a half for just one drink?
Roughly, yes. And importantly, you can't speed that up. Coffee, cold showers, exercise, none of that makes your liver work faster.
Yeah.
The impairment is there till the alcohol is gone. #outro.
Okay, we have covered a huge amount of ground in this deep dive. I think for you, listening, the key things to take away are that really important shift in medical language to alcohol use disorder, or AUD. Also, just how common hidden alcohol problems are, often showing up as those vague physical complaints. And critically, the real risks of alcohol, especially binge drinking, for the developing teenage brain.
And the good news, that effective help is available, often starting with brief, motivational approaches right in primary care.
Yeah, that early treatment piece is vital.
And this whole shift in perspective, driven by that stark data on cancer mortality, it really moves us away from fuzzy ideas of responsible drinking towards a much more cautious health message.
So it leaves us with a pretty big question, doesn't it? If optimal health, especially minimizing cancer risk, points towards 0 alcohol, how should we, as individuals and maybe as a society, think about that 1 drink maximum guideline versus aiming for total abstinence?
The evidence definitely pushes us to look beyond those old definitions, doesn't it? To focus much more on early identification based on actual impact, those DSM criteria, rather than just counting drinks.
It raises that fundamental question.
When is alcohol not a problem versus when is it a problem we just haven't recognized yet?
Okay, definitely something to unpack on your own time. That's all for this deep dive.